Peter is out ill today, so we're gonna cover for him, so be patient with me as I read his updates later in the meeting. Let's go ahead and start with introductions. You wanna start on the phone?
We should start.
Why we start here?
I guess we'll start here.
So you have the names for things.
I am Susan Pointier, Revenue Cycle Manager for Lake Health District.
Ann Casbon, Lake County Senior Center, Transportation Coordinator.
Francie Winters, Prevention Coordinator.
Vicki Taylor, Healthy Families, Family Support Specialist.
Brenda Arcee, Lake County Crisis Center.
Brooke Kelleher with Food Corps.
Okay, let's go to 7.
Kristen Hill, Facility Patient Navigator.
Paul McGinnis, Greater Oregon Behavioral Health and the Eastern Oregon Coordinated Care Organization.
Judy Clark, Director of Public Health.
Charlie Twig, District CEO.
And who do we have on the phone?
This is Virginia Farr. I just have I was part of Trauma Informed Oregon, so I just wanted to add information for that.
Okay. Estella, are you still
Good
there?
afternoon. Yes, Estella Gomez with Oregon Health Authority.
Awesome. Did anyone else call in? Okay. We will go ahead and get started. Jen was checking to see if we had any minutes because I didn't get those sent over to me. So I would anticipate us having May, June, and July minutes at the next meeting. Next was going to be the EOLA update, but do we have anyone from EOLA? I don't think so. I just saw a new face I didn't recognize. So I guess we'll just jump in with Kristen Hill with our update from her.
Thank you. So I'm here to give provide an update for our ED Utilization Grant. Over this past couple months, Sarah Bauer was able to come down and touch base with us, and she was able to get pre-manage implemented in our wellness center. So that's a nationwide network that we use that help connect emergency room providers and nurses with information for patients in a real-time manner. So that way we know, we can flag our patients and we know when they go to the emergency department. And then Abigail Finetti and I do this for our hospital, and we track the people that come into the emergency department. And we can get flags on folks and just to be able to better service them in a real-time fashion. Gobi was able to pre-populate into pre-manage these folks that are on our disparity measure, the folks that are the ones that we're trying to really reach out to. It was a little bit it was hard for us to be able to figure out who these people are that need to be reached, because a lot of them are uncoordinated in their care, and so she was able to do that for us, so that was really huge. And then also Eric and I, mostly Eric, have been integrating parole and probation into our IDT meetings. We have a lot of folks that are high utilizers that also are in and out of the jail a lot, and just trying to help facilitate their release so that we can get them immediately connected with their providers as well as wellness centers. So that's our updates for now.
Are we able to get some of those people that are in jail to still have their therapy going on?
Not yet.
Because one of the things that happens is when someone goes into jail, become incarcerated, coverage from the Oregon Health Authority does not continue.
So it's a huge barrier that we're trying to
That's
tackle
right.
now.
And they could be in for a day or two, they could be in there for an extended time period while they're waiting for something to occur. And that break in therapy is a real problem.
And that
And of
lapse
course-
in coverage when they get released is a huge barrier
Yeah,
for getting them to
that's what we're
see
seeing.
their provider and mental health. And from our understanding, that OHP ends after 7 continuous days in jail, not necessarily just one, but still that's a lot of our patients.
State of California actually covers for, I think, 2 or 3 months while they're in jail, while they're incarcerated. So that's a huge place that our state hasn't taken a position on. But we can figure out how to address that. In Lake County, maybe we can make some difference.
With that, I guess we'll move over to Paul for our RCAC updates.
Well, it says RCAC update. I did send materials to our vendor. I have like 3 things to do real quick. The first one is that the Regional Community Advisory Council met on June 26th and approved the Regional Community Health Plan. Our vendor should have a copy of that if anybody wants it. They also approved the annual report to the EOCCO board, which will be presented by Katie Brenneman, the chair of the RCAC, who's a member of the EOCCO board. And a couple of the recommendations that I just want you to have awareness of: the Morrow, M-O-R-R-O-W County RCAC or LCAC had written a letter to the EOCCO board of directors, basically saying that part of the process for using the LCAC funds was too restrictive. The idea that positions can't be funded permanently with these dollars was unrealistic for smaller counties. And the Regional Community Advisory Council endorsed that and put their letter into the report to the EOCCO boards, which basically says make this process easier, give us more freedom, and forget about that sustainability stuff. That doesn't mean that it's going to be implemented. We've had several recommendations that we keep going back to that have taken a couple of years to be implemented, and they have been. The reports that you get that I'll share on the incentive measures were as a result of this process, as well as the changes in the cost and utilization report. Those were all requested by the RCAC so that communities have a better understanding of what's actually happening. Although we do have Nam here. Where did she sit down?
Right here.
Oh, hey, Nam. And we had Susan and Juanita would show up. Many of our LCACs do not have clinics represented at their LCAC meeting, which makes it very difficult to coordinate for the incentive measures and meeting those measures. So our request to them last year and this year again is that when you contract with a patient-centered primary care home, which is what you have here, that something be inserted that says that if you're going to participate in this, you need to have somebody representing at a local community advisory council meeting. So
on a consistent basis.
Yeah.
Sometimes sporadic is not as helpful as not at all.
Judy can chime in on this one. Last year we requested that public health be recognized for their contributions to helping us meet the incentive measures, and the RCAC suggested a per member per month payment to the public health departments. And that was debated and rejected, and instead a pool of about $500,000 of the local, or of the incentive measure dollars is dedicated to public health. I don't know how active you are on the modernization group and what their thinking is about the application now.
It's hit and miss for me because it's all webinar, and if I have patients, I don't get to sit in very often.
Okay.
But they're talking about it. I don't know the newest.
So the idea is that rather than Lake competing with Harney, competing with Mount here competing, that they'll use this modernization collaborative and try to figure out one application for the use of the $500,000.
Oh, is that right?
Yeah. But we still recommend that instead of having them jump through a hoop and going through the process, that we just kind of recognize it as an overall contribution. There was debate about traditional health workers, which include our patient navigator here and community health workers, and I'm not sure how many you have here, Charlie.
We have several. So we have, excuse me, a couple in mental health. We have a couple in the clinic. We have in different locations. We have a couple in the hospital.
Okay.
So their role is different in each environment. What is needed on an inpatient basis is absolutely different than what is needed in a mental health or a wellness center or in the clinic setting or in public health for that matter.
So we have had an increase in community health workers. The Eastern Oregon Coordinated Care Organization was the first in the state to create policies that allowed for community health workers to bill for services. But it's a limited amount of things that they can bill for. But it also makes you eligible for the wraparound payment from the Oregon Health Authority for your full reimbursement as a rural health clinic, the services that are there. So
as an example, you have to have an in-person contact between the community health worker and the client or patient. You can't do telephone.
even though a lot of their work is on the
A
phone.
lot of the work is on telephone because it could be the family or the person you're trying to work with has kids and can't get away. And I mean, so it's a limited way of providing that care, but it's still better than nothing.
So the CCO's new contract has a section in it about community health workers that we're going to have to bolster. People had talked at the RCAC, but it didn't make it into the report about some sort of PMPM for community health workers, whether it's just a small amount to recognize all that work that they do that's not covered by the 2 billing codes that you can get. But it didn't make the report because there's so much up in the air on that right now. But what the RCAC did suggest is that every time Christie writes a grant or somebody else does that includes a community health worker, the grant reviewers always say, we want that position to be sustainable, right? And there's a limited number of things you can bill for. There's no way it's going to be covering their cost of training, their ongoing support. So what we're recommending is that the EOCCO data analytics conduct a study to determine the overall cost-benefit impact of a community health worker. So that way, the local communities can justify it and say, this community health worker worked with these 30 people. Last year, their total spend was this for healthcare. This year, it's this. Isn't that where the savings is and what should sustain the position? And nobody has done that, so we'll have to start, and there'll probably be some kind of group that's formed to actually determine the parameters of that economic analysis.
Has there been any talk about providing some financing to help provide service in the schools as a setting?
If they're affiliated with a contracted organization, then that work could happen in schools.
So
I couldn't, but like Will's not eligible to have a contract with the EOCCO for providing health services, right?
but everybody, all the counties have an ESD.
True.
And all the ESDs have a vehicle for working on that and for providing some service to the other schools.
That's recently, we used the ESD to initiate student health nurses across the county schools.
Right. So I think that one thing that we might...
But they don't generate a claim that would come to an organization, and that's where we're limited.
If whoever is implemented in our situation, is there, because the place of service isn't necessarily what the hang-up is, it's being affiliated with someone who's contracted, so if...
The bigger issue is, can you bill for it?
We should be able to...
I know, but if you can somehow get away from having to bill, that you could have encounter data, you could have some tracking mechanism, but either on a PMPM type of basis or on some other mechanism so that we don't have practitioners too focused on billing and more focused on, because if you have to count noses every time, And then you have to find out what are the child's situation, because in the school it's gonna be a child. It becomes cumbersome. And if we can make it so that we can get the care to those individuals on an easier way, because after all, we're having a touch with them. And maybe it's getting names and tracking that. But we ought to be,
Put us on hold.
does that make sense?
It does. Well, I think we need to let this thing kind of roll out and keep that in mind as they determine how the touches are going to work. The last recommendation deals with coordinated media. If you happen to drive around the region, a lot of LCACs use some of their resources, whether it's through the opt-in grants or that kind of stuff, to purchase billboards and things like that. And it would just be better if it was all branded the same and the billboards were up and around and just done through the EOCCO to promote the common things that we want to see done. And the themes would all be those kind of things that Outback Strong is, trying to promote through its paid media, really. So that was that. Any questions on that? We expected we'll hear things over the year.
I have a question, and it kind of piggybacks on that. You talked about what you guys are advocating is to change, you said something about advocating for change of a billing code process thing? So that's within...
To include more things for community health workers, but we did not make that specific recommendation because we already got word that stuff is in the works
but it's
because
within,
of 2.0.
within EOCCO's purview to do that kind of thing. Because this came up recently and more than once, that there's a billing code issue about you can't have two services for wellness in the same day. And
That's a Medicare.
Okay, and there's no way that EOCCO could work as somebody that potentially might advocate for a change, because that seems like a big health equity issue to us in the rurals. People make the trip in, they want to get everything done in one day, and they can't see these. So I didn't know if that was something that EOCCO we could bring up to them.
Well,
it's actually it's a Medicare rule.
Okay.
And that is you can't go to two different doctors that are both of the same specialty on the same day for similar service. Because then the potential for fraudulent billing could occur. And if it is a potential, you can be assured that somebody has tried it. And probably somebody's been doing it for a long time. And then Medicare figured out that that was occurring and they put up a rule to stop it. And that's really the crux of what you're asking.
Yeah.
If I think that's...
And it goes even further that you can't treat any other patient any differently than a Medicare patient, so really it ends up falling to all patients. Same thing happens, you can't bill for a clinic visit and an ER visit in the same day.
Right.
So it's kind of across the board.
Yeah. Thanks.
So I'll turn to the dashboard report, which is the cost and utilization. First thing you may notice is, hey, we're back to South and North Lake. Last year, we got the report, and I wrote back to Liz Endenberg and said, hey, we usually split North and Lake County, and she's automatic email came back, I'm on maternity leave, see you in 5 months. So we got ahead of the game, and here's the cost and utilization report. And I just want to emphasize the transparency of this, and it was recognized by the Oregon Health Policy Board right in this room when we presented a few months ago. We shared a couple of pages of this with the entire EOCCO, and one of the members said, you can share this? I said, we give it to everybody. So, I mean, if you really want to know how we're doing, or especially in South Lake, and I can get you the EOCCO report on the whole if you're interested, but this is where it is. And so I just want to point out a few things. Our membership is going up. We now have over 50,000 EOCCO plan members, and there was an increase of 8.6 here in South Lake County for the year 2018, January to December.
Number of people?
that are enrolled in the Oregon Health Plan under the EOCCO. In South Lake County, it's 1,173 people. The plan paid per member per month is $481. That's up 7.3%. And the total spend for those 1,173 people was a little less than $7 million. So if you can cruise to the next page. I don't know what happened in October 17th, but that's the big jump on the graph down there at the bottom. But the current paid per member per month, $481. Last year it was $448 with that 7.3 increase. We have on the upper right graph, there's been a decrease in inpatient care, which is what we're after. An increase of 22.5% in professional, which includes the primary care and specialties, which we want to see an increase in that. We don't want to see a decrease in the spend on mental health, but we're seeing that, and pharmacy has gone up as well. Next one. Yeah, question, Charlie?
No, I was just going to say, probably the reason for the spike in October was more than likely a neonatal intensive care, a very expensive patient.
Back at that time. That's October 2017, not 2018. Okay.
And so what you would see is that would not be a service that we would deliver in the county, but that it would have been delivered outside.
Right.
And so that still is an expense that we experience. So that everyone gets an idea, just to put it into why we track this. If an average delivery cost, let's say it's $15,000, does that sound about right?
Vaginal delivery is about 10, but.
Okay, about
between 10 and
$10,000. We have about 65 to 70 deliveries in Lake County a year. Of those, about 50% are in ELCC, maybe a little higher, maybe a little lower, but roughly. If of those, let's just use round numbers, if 30 of those deliveries, that's $300,000. One of those deliveries, of those 30, went to a neonatal intensive care over in Medford or in Klamath, or in Bend. One visit can cost $300,000. So you can see why it's so important to focus on keeping those patients out of that neonatal intensive care. Now, they may still need it, no matter how hard we try to take care of those moms and then the babies. But that's what can cause the spike.
And what do we do to keep them out of there? We have an incentive measure that relates to timeliness of prenatal care. We also have postpartum care that's part of the measure as well. On this one, the point here is just one. We have 37,245 service delivery units. So there were that many services applied to those 1,142 people. If we go to the next page, there's all kinds of detail there on what those units were. So you'll see, the number of the first one of inpatient acute, 1.2 million. The per member per month, there were 72 of those services for inpatients for those 11. And again, you got this sent to you, so you can look at the details if you'd like, but it breaks down everything that we have into a specific category. We have Francie reporting on alcohol and drug, but you notice that the chemical dependency under mental health was down 23%. And you can also see when there were issues with having coverage down here with Advantage Dental, that the dental service went down last year 16.5% in terms of utilization. It just shows up. I mean, these little things that we talk about, ultimately they get there. This next page is a real transparency thing. It says, what happens, you have X number of members, how much money do you get for each one? And what happens to that? The populations are on the rate groups, bottom left. ACA, that's the Affordable Care Act. There's 479 of the 1,100 people are covered under that. That was the expansion program. What Charlie was talking about, though, is if you go down to child 0 to 1, last year, 2018, there were 24 that were part of the EOCCO. The year before, there were 31. You'll notice that our payment, what we get currently for each one of those kids 0 to 1 years old, is $560.97 per month. That's what the EOC gets for them. There's a couple reasons for that. First, newborns go to the doctor about 8.3 times per year, right? The other thing is that payment recognizes that there could be neonatal intensive care services. Because if you drop down to children between the age of 1 and 5, our payment is $179. Those are all rate adjusted because of the risks that the patients have. And certain categories that have Medicare and Medicaid, the people with disabilities at $1,389 a month. But again, this is about as transparent as you can get. This is what money we get, and on the other side, it's what money we spend. Next one is the key indicators overview. You can see at the bottom left where the actual paid plan, that's the gray in the graph, went above what we got paid. So there were some times, certainly during the year, where we were way under budget here, and then times when we were over budget. But it's pretty close. Bottom right is pretty interesting. The far bottom right, 4.1%. So 4.1% of those 1,172 people spent 42.6% of that $6.5 million that we said that we had to spend. So most people who are using the Oregon Health Plan actually aren't big overusers, but that's a perception in the community sometimes that the system is abused, but it's not the case at all. The next one is the emergency department use. This was for you and for your grant and pre-manage and Eddie and the other things that we're trying to do. And the interesting part here, first of all, look at the trend line from January 15th to 19th for this population. It's going down. That's what we want to see. Bottom left are the details. You have the number of emergency department visits. So as an example, we go down that column and we see the number 3. So how many people had 3 emergency department visits during that year? 32 of them. That was up from 24 the year before. But again, you probably could put a name, but we're not allowed to talk about that for HIPAA purposes. And then broken out over on the right-hand side is the age breakdowns of who those people are.
But you can also see that there were 2 people that had between 8 and 10 visits to the emergency room. That's almost once a month.
Yeah.
Those are the ones we want to help find a more appropriate place to go for care.
Right? You can almost focus on 4 or more. Sure. But the 3, that's kind of random. But look at how many didn't have any. 831. So 70% of them didn't have any ED use.
Yeah.
Next one is our primary care trend, which is, if you look at the upper right, since 2015, woohoo! More people using primary care means less hospitalizations, less emergency department utilization. And it's trending the proper way. Of concern for me, for Lake, is that most of my counties went down in terms of not using primary care. So you're looking, okay, so bottom left, how many people had 0 primary care visits? Of the 1,172, 490 consumed nothing, which represented 41.7%. The prior range was 37.3, so we're trending wrong there in terms of utilization. How, if people don't come to actually see NOM, is she supposed to deliver the incentive measure services that are required to be done? That's the problem. So,
Paul, does those numbers include the walk-in clinic or urgent care visit when you're using the term primary care visits?
yes.
Okay.
Yes, it would.
Okay.
Yep. And then this report changed as a result. They used to just show us this, and they didn't have that characterization in the bottom right. And people would say, well, who are these people? And so we asked for demographics of who those 41% are. You have the age right at the bottom right, and then the next page by age and gender. And an additional one that the RCAC had asked for was, where are these people assigned to a patient-centered primary care home if they're not going in? So for the, where were we at? 490 that didn't consume any services, 407 of them were assigned here at Lake Health Clinic. Scott Graham's got 38 of them, 26 are just kind of floating around somewhere.
How can we deal with that? Get them assigned?
They're assigned,
They're
they're just
assigned
not
to
coming in. They're not
Well,
utilizing
no,
services.
this is saying they don't have one yet.
Oh, I'm sorry.
They've probably consumed no services ever since they've been on the health plan. Because the way that they get assigned is if you actually end up going to somebody, then they'll assign you to that person.
But I thought,
If you go to multiple ones, they look over time and then assign the patient.
The majority of the people I work with tell me McAllister is their primary.
This is the facility they get assigned to, so either Lake Health Clinic or Graham is a choice in South Lake.
So even though somebody has not his established primary, they're still showing on here. Is that what you're saying?
If they went, it wouldn't show up here. If they went to McAllister or whoever that is.
Well, he's the walk-in.
Oh,
But it's
okay.
my understanding he doesn't actually
right.
have.
But this is saying that 407 patients are assigned to Lake District Hospital, but we have not seen them
For primary
for
care.
primary
They
care.
could have come in the ED, they could have had other services, but,
But we didn't see them for primary care
right,
at Lake Health.
Including walk-ins. We
Right.
didn't see them in
Because
walk-ins.
these are claim driven, is that correct, Paul?
say it again.
These numbers are claim driven?
Yes. Yep,
As in the people will say that that's where their primary care is.
No, as in a facility dropped a claim for that patient
Mhm.
and their assigned PCP is Lake Health Clinic.
So for example, the 3 people that have gone to Blue Mountain and John Day, that's a long drive for primary care services. But if they're a traveling person,
no, those 3 people are assigned to the Strawberry Mountain Wilderness Clinic. They've selected that as their primary care home, or to Harney District Hospital. And during 2018, those 3 people never went up to John Day. Or used primary care, same with Harney people.
Part of why we check when they're checking in to see who their PCP is, we can still see them if we're not their PCP, but we can't get services authorized. So that's why we encourage them to, if you're gonna continue coming here, great, but let's help you get that reassigned.
The ER doesn't ask who your primary care is, correct?
Yes, they do.
They do.
I wasn't asked when I went a couple weeks ago.
Did they ask you if you felt safe at home?
But I'm just saying, like, and that was something that I was not, I thought
I went in
about.
for a colonoscopy and I got
Did you
screened
meet
for
the follow-up?
everything.
They might only see you when you're
is that right?
But I'm just like, I don't know.
They know you're there. They just have to see you.
My understanding was yes.
Okay.
So you guys, again, you gotta have this sent to you. I'm sorry if it wouldn't open for you. I don't know what to tell you, but,
We can print it for you.
I'll try again. I mean,
but the next one is for specialists. We want this to go down. It's trending kind of flat on the upper right. The non-primary care office visits are mostly in the bottom right related to musculoskeletal and connective tissue, and those health services is just a big catch-all category using the ICD codes. But you can also see where people went, you know, whether it's Lake District, and that's the top 10. A lot of bang for primary care, or for orthopedic care. And then Charlie mentioned the maternity, and then I saw this big blip again about the same time, you know, in October. So this may not have been a neonatal, right? Because it's non-maternity. But if you get moved to neonatal, is it considered a different category? Do you think inpatient-wise? What's that?
Oh, I was looking for where you were looking at.
No, this is it. See the big blip again?
Yeah.
And, you know, we were thinking maybe, but I'm not sure if you're admitted as a neonate, whether that's considered non-maternity care, or whether it changed and you become your own patient. And
Yes,
then
yes, you become your own patient at that point.
So that's probably what happened there.
Could have been a trauma too. Or...
Yeah, out of the grand total of 1.2 million for non-maternity care services, 685,000 was paid here to Lake District Hospital. So 51.2% were able to stay at home.
What's PMPM?
Per member per month.
Oh, thank you.
So,
Does everybody know what PMPM means when you say per member per month?
It's pretty self-explanatory, I think.
Okay.
You've got 1176, and how much you spend for each
So-
one of them per month, right?
So think of it like this. If you go to the doctor and it is $80 for the visit, and the predictions are that you're going to go twice in a year, that's $160 in course of care. Plus you're going to have some lab work. So let's say that total is $250. That's the estimated amount of money that you're going to spend going to a doctor and getting care. If you take $250 and divide that by 12, it's a little over $21. That's $21 per member per month. Okay? So if you were to spread it out over the 12 months, you got paid the $21 every month, it would estimate how much money would cost for that $250. Now, if you went more than twice, you're spending more than the per member per month. If you went less, you're spending less. Okay?
the key is having a big enough pool of people,
Right.
P-O-O-L, pool of people, that you can withstand those blips where 4.2% of the people spend 43% of all the funds.
So that's why we're pushing the preventative care, so
Right.
spend less money, keeping them healthy, then more money.
So we have several pharmacists. We haven't had a pharmacist on this LCAC, but when we first presented the utilization report, they said, hey, what about drugs? You spend 20% of your dollars on it. What do we know about that type of spend? So I'm not anything expert on pharmacy, but I will point out on the last page there, Susan, to get to it, upper left, third one down, the highest number of prescriptions is still for opioids.
Really? I thought we kind of, Oregon said we're not doing that anymore.
Well, that doesn't mean that you're not injured. You'll get opioids for shorter term. It's the lower back ones where all the restrictions are on long-term use. But I don't, you know, pharmacy people can have a big impact on the total spend on a patient. There's just no doubt about it. So these are there if you want to share it with any pharmacist. You're welcome to do so. Any questions on the cost and utilization? I'd summarize it by saying this. We got primary care going up, emergency department use going down.
Specialties flat.
Specialties pretty flat, inpatient, slight decline, and pharmacy, it just keeps rising.
Is it because of costs of drugs, do you think, or utilization?
Both.
Was the easy answer.
So when you think about opioids as an issue, we've been
They're
addressing
actually
it.
cheap.
When you look at the cost, you look at the most volume, the third one down, the opioids, 9%, 1,000 drugs. Look at the cost.
Yeah.
$1.76. So it's a lot less than bronchodilators or anti-inflammatories.
But so there's a lot more of them going out though in order to make that happen.
It costs less.
And if we could go to that last report, we won't spend hardly any time on it because it's the first one this year. You're still under for the emergency department utilization.
Do you want Lake or what do you want here?
Is that?
This is everybody.
Oh, go Lake. Go one more. Just Lake.
Baker.
Oh, you gave the whole route, huh?
This is the everybody.
You're next.
There we go.
Lake is always right behind Harney.
I don't like that. Well, these things happen.
So I did send our vendor these two additional things. That at the bottom, they've changed it because they're recognizing too that we just can't make it work without people using primary care. So it's not a measure that the state pays us for, but we want to be tracking it. So it's the established PCP care, and it's whether or not you've got a primary care service from the person that you're assigned. And then the morphine equivalence dose roster, there's a description that our vendor can send out that defines how that's measured. Other than that, we're still below for the ED use. We got the 81 or less for people experiencing mental illness using the emergency department. But you've seen these reports enough to know that the key is the right-hand side. And it is official, we did get all of the withhold back for 2018 plus an additional 300,000, I think, in the incentive pool quality measures. So we have like 12.4 million to distribute. And that process will start.
For the 18 measures or for 19?
2018. And so the LCAC will start planning its use. It'll be a little bit more money than, where's Christie? It was, I think it was like 39,000, just dedicated to this, that you could pretty much do what you wanted to. And then she'd go after the opt-in grant. So there'll be that much, if not more, available.
And they will follow between this and the LCAC 5-year developmental plan. We'll choose the things that go together on both.
No, you can fund either what's in your plan or something that's dealing with it in some.
Okay, so one or the other, not the overlaps, okay.
Yeah, well, you could do it overlap, right?
As long as one's not dependent on the other. Right?
You can't
Or
tie,
that's the
you
grant,
can't
the
touch
options.
you can't tie the budgets together. Yeah. Thank you. That's that.
Do we happen to know when the 2018 results are coming?
You mean what?
Like when the announcement for the final, has everything been calculated for the 2018?
It'll be the end
September.
of August, first part of September.
Oh, no, it's out. You mean for the whole of the EOCCO?
No,
by
each county.
each county.
Um,
Whether we met all of our metrics.
Within your clinic?
Yeah.
Okay, that's a different story. It should be coming soon.
Right. We're just hoping it will be sooner.
Okay.
It is hard to wait a whole year to know how you did.
This was fascinating.
Well, you can see, you get to see what you did last year, where you were at this point in time. So, the adolescent well visits, at this point, last time you had 22 out of 281 done. This year, to this point, it's 33. You still need to do 105 to meet the mark. That's that. Sorry I took so long.
That's fine, thank you. We are going to sneak Miss Ann in here with, did you want to go ahead and talk about your senior center update?
Certainly. I want to give you a brief update on transportation at Lake County Senior Center. We have long felt that transportation for medical purposes is an important part to community health. So we have seen an awful lot happen since the CHIP program has begun, and since our current executive director, Andrew Wishart, came on board, where 4 years ago we had one bus on the south end, one on the north, and we were operating under having too much money and not enough ridership. Oh, how things have changed in that time. At this point, 75% of our mileage is going to non-emergency medical transport through OHP. So 75% of the miles and the time is going there. So we have been able to marvelously expand our medical, providing services for seniors and those with disabilities and those who are low income and to get to medical appointments in, say, with less money in a way. So we are still emphasizing medical care, but we have gotten our new grants for the biennium, and we would like to be able to extend a certain amount of service to other people who are not being covered by OHP. So please talk to me, talk to Noelle. We've been working together as one of the healthcare coordinators to try and get folks to their appointments. We also are able to make some trips for things like the OSU Extension has got a garden tour on Sunday. We're hoping to be able to extend that there and to Playa. So we're trying to build wellness not just through medical appointments, but we're trying also to help sustain seniors and those who aren't getting out with a bit of social activity. We'll be seeing an additional grant coming in October, which will be able to extend shopping trips again to those with low income. We are going to be doing a shopping trip on each end of the county for better access to nutritious food to help them get their food stamp money going farther. That will be implementing in October. And we will keep you apprised when we've got dates. We're also connecting at that point to other transportation via going to El Toros.
Okay.
So in the community health assessment, in 2015, there were 812 rides. In 2017, there were 1,990. So there's your boom. All of
Yes, sir. I feel it.
And just to add on to that, from the clinic end, we are making anywhere between 3 to 5 calls a week, and most of those are either same-day calls or the day before to get patients to their appointments. We are seeing a spike in that too. Sometimes it's one patient, sometimes it's the family that has no transportation. So transportation has been a huge help in the clinics.
Yeah, glad to hear. Thank you.
How do they coordinate? I'm confused because do they call Mid-Columbia and Mid-Columbia contacts you? Do they call Translink? Or is it separate?
Mid-Columbia.
So when people are on the Oregon Health Plan, they're contracted for, there's money paid to Mid-Columbia and Translink to transport them.
They were.
They still?
Yeah, no, the Mid-Columbia Council of Governments dissolved.
They changed, yes,
Greater
changed
Oregon
it to
Behavioral
Go.
Health
Yeah.
operates the call center internally.
Yes.
So is that
contact Gobi.
And then they schedule with you?
Gobi determines eligibility. If they aren't Gobi, then they're going to be TransLink. The open cards are going to be TransLink.
Yeah.
I'm working on that contract to secure TransLink. For some reason, we didn't get that contract. That was before our time. We didn't have the capacity to provide transportation for TransLink riders. So we're hoping to be able to offer both.
Oh yeah, that would be hard because anybody who's dual eligible would be with TransLink.
Yes, and unfortunately right now the closest contractor is Klamath Medical Transport, and not only are they strapped with their meeting, we would prefer to take care of.
Well, they have people driving from Clemens Falls to Lakeview to take somebody to Bend and then.
So I'm working on that contract, but yes, they would contact Gobi directly, or they would contact
whoever they're
To
assigned
Translink,
Is
yes.
that like where they come from Klamath and they come over to pick them up at their house and drive them 3 miles to a
Yes.
doctor appointment and then they go back to Klamath?
Yes.
Or even to Bend, it's still.
Or to Bend, yeah. That's,
During 12-hour days.
And J.D. Herman at the long-term care, the social worker there, has been instrumental in helping us get that contact going with TransLink in order to be able to provide, he got us the connection to the people to talk to at TransLink about getting that contract, so that we don't need to put our senior citizens through this either. Because during February, March, they canceled a lot of rides because they didn't want to come work with them because the weather was awful. We knew the weather was awful. But this left senior citizens, especially in a position where they couldn't provide medical care because TransLink would bring not acceptable. So much.
Yes.
Okay. I'll go ahead and share our vendors' chip updates that he sends me. So for our summer food program, we started on June 10th, and we've been averaging over 90 lunches every day. The McDonald Kitty Park and Lakeview Commons North are 2 of the main sites. Other than the week-long sites at school, OSU Extension and Bible Studies Camp, the Lakeview Commons North is the underserved population site, and we are seeing numbers of lunches double or triple there compared to last year's food program. We have people from our community and health partners volunteering several weeks of the food program, and we are grateful for that. This year we have 2 backup sites in case of inclement weather, the Lakeview Public Library and the AD Hay School Gym. A big thanks to Amy Hutchison from the library and Susan Warner for letting us use these sites. The Senior Health Fair. After the successful Elder Abuse Awareness Day event that was held at the Senior Center, we had a successful Senior Health Fair. This was the 2nd year for the Senior Health Fair at the Daily Days Health Fair, which was organized through the Older Adult Collaborative and involved stations from Lake County and Klamath County health agencies. We saw a larger turnout than last year's Senior Health Fair, and were able to sign up adults for several of our health-related programs. This year we will advertise the Village Initiative, which is being led by Klamath and Lake County's Council on Aging. We were able to sign up volunteers for this project and also noted down community members who will need assistance through this project once it's launched. The Senior Health Fair was also successful in handing out colorectal cancer screening kits and flyers informing people of the convenience of this method, and I have heard quite a few selfies were taken with good old Nolan colon. Some of those, I believe, may be on Lake Health District's Facebook page. Definitely worth looking at.
I think specifically you're supposed to take a picture with the polyp though.
Yes.
They did.
They did.
They did take it with the follow-up, the one I saw.
That's what the cool people do.
Never too early to start school. Living well classes.
We have doctors that can take those polyps out.
The Living Well classes, it says they completed the 6-week Living Well with Chronic Pain classes recently, which were held at the Senior Center, and are on track to start the Living Well for Chronic Diabetes classes next week. I just heard from Kristen, though, that may be moving. Do you have any update on that?
No,
chronic
it's still
disease.
planning on the 18th, and it's chronic
Chronic
disease,
disease,
and so
okay.
far they have 4 or 5 folks that have confirmed.
Oh, good.
Still making phone
Is
calls.
it still Erin who's doing that? She was doing the diabetes one?
Oh,
She's
that's a
doing the
support.
diabetes support group.
Oh,
This is the
that's
Living
different,
Well
okay.
Chronic Disease class.
So that's yours, that
Well,
It's
no,
Kristen
not that.
and
Yeah,
Noel.
Kristen and Noel are going to do this one. I got an excuse from the principal.
We successfully hosted 5 diabetes support group meetings at the Presbyterian Church, and we'll be taking a break during the summer as the turnout will be low for summer. Plan is to relaunch the support group meetings in September. Our Seroptimus play structure at the Seroptimus Park, we are very close to finalizing the purchase of a $10,000 play structure through the LCAC funds, which will be placed in the Seroptimus Park. The Town of Lakeview office has been a wonderful partner throughout this process. The play structure will be purchased no later than next week, and more details will be shared then with the Advisory Council. Incentive measure updates. The Adolescent Well Care Measure 3 grand prize drawings were carried out. Winners received a mountain bike, Fitbit watch, and an all-season swim pass. Drawings for North Lake Clinic are due. Next round of Adolescent Well Care grand prize drawings will take place in late August. So far, we are doing better than compared to last year with the prenatal, postpartum, adolescent care, and developmental screening measures in the clinic. Food Corps updates, we have a new Food Corps service member program, for program year 2019-2020, Lake Health District interview panel. We're very happy with the service member interviews and are excited for her to join Lake Health District and continue the great work that Brooke has done. Helena Van Brande will be arriving in Lakeview on July 28th. For the rest of the Food Corps updates, Ms. Brooke can share with us.
Yeah, I guess really the only big thing is we've been doing our Cooking Matters program. So we started that, we're about 3 weeks. Yesterday was our 3rd week, and it's a 6-week program. Michelle's been a big part of that, planning with that. And then we also used some fresh dill yesterday from Francie. So, and I would say that that's probably the best part of this is it's not just what we're doing for the families, but it's the amount of volunteer support that we've had. There's a lot of people, we have 2 volunteers from public health, and just a lot of people who are interested in supporting the program. So it's going pretty well.
How many you got? You started with 9?
So we cut it down to 5 families.
Now, but
Yes.
did you start with 9?
Yes, and then it quickly, we switched to 5 just because that's how many we had. 2 have to switch last minute, and then, anyways, we decided that 5 is the best number, too. I've had a lot of families since signups started calling and saying, hi, I know about this, I would have signed up, so I do see that there is another need in the future. But I'll also say that last night we had only 1 family sign up. And we were really lucky that we very quickly had some families in our back pocket that we knew wanted to be a part of this, which isn't how the program's supposed to run. Because you do a pre and a post survey, and that's what the people who are funding the program are funding it for, to have that deep dive. But we had all the food and everything ready, so we figured why not, and the people who came were really, really grateful for it. So,
Did you still pre-test them?
No.
You could have.
I probably could have.
You could have, because they might stick through and you'd get half.
It was a really last minute jumbled together, but we had an awesome time last night.
Cool.
So, yeah, it's going really, really well, and I would definitely recommend people do it in the future, and hoping that EOLA is gonna stick by them possibly taking that on, because I have a whole binder to give to them.
We'll miss you, Brooke.
Yeah.
Thank you for your service
Sure will.
for your service to the community.
Yeah,
Good luck
absolutely.
in New England, I forget which state.
New Hampshire.
Yeah.
All the New
Vermont,
England
New
states
Hampshire,
are
they
the
kinda
same.
look-
We're all one.
You're gonna miss it here,
I know. It'll be strange leaving.
especially in winter.
Well, that's how New Hampshire is too, so,
Yeah.
yeah, we have some crazy winters, so I won't miss that.
Like you can fit all those states into Oregon.
I know. Actually, area-wise, Lake County is the same size as New Hampshire.
Really?
Yes. Yeah.
5 times the size of Delaware or Rhode Island. I can't remember which one, but it was.
Rhode Island's very small.
Rhode Island is very small, so it's like 7 Rhode Islands and 5 Delawares. So, whoa.
Talk about winter, I bet you can't wait to get back to that humidity in the summertime.
Oh, yeah, right.
I love the humidity, so I'm excited.
We part company on that one.
And you're the person,
Helena.
predecessor was the one before,
Rochelle.
Rochelle.
but the one coming in, what do we call that? Predecessor? or-
Successor.
Successor, yeah. Thank you. She's aware and during the interview process, because we did, because if you put that into the regional CAC plan,
Uh-huh.
and it was approved, that where Food Corps exists, we do a better job of connecting.
Wow.
So,
That's awesome.
and right now, we only have 2 in our region, Union County and here, so.
Union has a food
Yeah.
court person?
Yep, they were new this last year, and then I'm really excited for this coming year because Klamath Falls just got one. And it's with the Extension Office over there, who I work really closely with. They give me so many resources through their extension, their SNAP Ed program. It's called Food Hero. And so I'm hoping that having another Food Corps person is just we're gonna have even more resources and connections from that side of stuff.
So I don't know whether last month, I mean, the EOHLA report may have been that Gus Shoemaker nutrition grant did go in, which would fund the Frontier Veggie RX program in Lake County.
And that was supposed to include.
That was submitted.
a education portion.
Yes.
Right.
The new sites, you have to have an education piece with the voucher program. We're gonna try to get it done in Harmony, but I think people are gonna push back. They're gonna say, I've been getting these vouchers for a year and a half or 2 years, and now you want me to get educated? So we'll see what happens. But as a condition of getting your 30 or 40 bucks a month or whatever, I think the budget withheld, saying you need to do this, people are being more willing to do it.
Yeah, the great thing with Cooking Matters, we are sending them home at the end of each session. They get sent home with some of the ingredients that we were cooking with. And then they also, I mean, last night, Michelle's been really great about our incentives that we're giving out. She's been organizing that stuff. Last night we gave out oven mitts, spatulas, cooking mats, like cutting mats.
Conversion charts for measurements.
And then in past weeks, they've gotten like measuring cups, measuring spoons, so many, they're getting everything.
That comes from the Cooking Matters program?
So the Cooking Matters program just comes with the booklet. And did they send us anything else? Oh, and a bag. But it's part of the funding that we're supposed to get that we fundraise. And so actually it's been mostly Food Hero over in Klamath Falls. There's also Jamie Davis, our extension office is connected with that too. But they, all of the stuff says Food Hero on it, so they're just trying to get their message out. So it's really great quality stuff. And then we've had funding from Take Root, the parenting hub. Federal Marketplace gave us $100 for just putting their little pamphlets up. That's all they do. And then the extension office, since this falls under what they do, they were able to use a lot of their programming dollars for us. Our Lake County extension.
And that might, cooking stuff might sound like, oh, that's just kind of, frilly. But the truth is, when families have to leave suddenly because of violence or whatever, cooking stuff is one of the first things that gets left behind. And so cooking equipment is really a big deal for those families. It really does help.
And Francie's donated a crock pot, so we're going to be giving that away. Not raffling it, because that would be gambling, but we'll be giving that away at our last.
Sounds like you have enough, short enough families.
Randomly giving it away.
And I just want to say, last night especially, I realized how much I love this class for me personally. I mean, community members, Joe from Public Health was there, community members that I work with and talk to on a daily basis. It was just a different environment, and you get to know people better, and I love it, even if the families don't show up.
But I do have to say the greatest part was how many volunteers we have and people, and a lot of them have kids right now in the school system, and we were talking about like they're just learning more about what Food Corps does, and they are interested in the future supporting more cafeteria programs, helping out with like taste tests that Food Corps does, supporting the garden and things like that. So having these things, I think that's one of the greatest things about it is people just get really excited and want to be involved more in other things. So.
Oh, and I met someone who's been living here and working at Houseboat for a year that I didn't even know existed. And she was great. So,
Yeah, well, that's all I got.
Okay, I unfortunately don't have any grant updates. Christy is busy working on her EOCCO grant reports so that we are in compliance. So we'll let her update us next month on all of that. Francie did share with us some information on alcohol products. You want to?
Just very briefly, I only picked one page, the most pertinent, I thought, and just to say that the next page that talks about some other, it follows the same pattern. If you look at this, that we did a retail assessment, Jill Harlan and I, when she was the TPEP, and we went all over the county, and we looked at every retail environment in the county. And we checked on alcohol and tobacco, on placement, and so what advertising is outside? Are they price promotion? Are they advertising candy-flavored cigarettes or whatever? And then when you walk into the store, where are these things? Do you walk in and you're bombarded with alcohol? Or if you're 3 years old, are you walking in and you see this whole thing and it's alcohol and it's at your level? Or is it tobacco? The flavored cigarette stuff or whatever, is it down at the little one's level? Because the more you see that, the more it becomes normal and the more likely you are to begin to use. And one of the big ones is how close are the toys and the candy to the alcohol or the tobacco or the whatever. So if you just pick out any of those that look interesting to you, but look at our county. We have so many awesome zeros. So when the state was like, well, if you found some ways to do it, and I'm like, you know what? I think we should write a letter to our retailers and thank them for doing such an awesome job and include this and say, there's a few areas that maybe we can, and if you want, and explain what it is that and why. But I really think that we have some awesome retailers and they deserve some kudos for what they are doing right. Because we did have 25% that had alcohol placed near the candy or toys within 12 inches. They were super small locations. And they probably never thought about it. Although the alcohol and the tobacco folk that come in are really sneaky about that. We want this here. We'll give you a price reduction if you put it here. So they're very, very sneaky about those things. Maybe sneaky is not the right word, but anyway, I just wanted to share that to you and so you had a chance to look at. We have them on more extensive ones, and we also have it on tobacco. But I thought I'd start with the alcohol one because the state, the 2-year plan for the state is really demanding that we are focused on excessive alcohol use across the state because Oregon is, excuse me, we have twice the alcohol use the average the rest of the country, and Lake County has a higher rate as well. So if you add all that up, then we have a lot of alcohol use and we need to try to look at that and the health issues. So that's
Nancy,
all.
are you saying that this data set is available in every county?
Yep. I can set,
Well,
actually,
I'll do search and find.
yeah, they can send it to you. They sent us each of ours separated, but they have the whole tamale too.
Okay.
Yeah.
Thank you.
HIPCA, right? Health Promotion Chronic Disease Prevention people. Yeah, they have it.
One of the nice things about being a really small county too is I walked in Howard's one day and all of their e-cigarettes were right there in front of the cash register. And I said to them, what the heck? And next time I went, I said, this is exactly at level where the children are going to be accessing it, where the teenagers are going to be pocketing it. You are promoting e-cigarette use. Well, apparently, next time I went back a couple weeks later, it is all gone. So use your power.
There's just little
I don't know if it had anything to do with it. I don't know if it had anything to do with it, but.
No, that's great. Yeah.
Okay, I don't have anything else. We do have a couple more minutes. Does anybody have?
See if Estella had something since
Oh,
she checked
I'm
in.
sorry. Estella, do you have anything for us? Are you still there? I heard a couple people leave, so.
Well, I was gonna let her tell you, but we did get this 5-year extension on the CCO contract for East Shore. Gobi, as a separate partner with MOTA, was denied in the northwest corner of the state. So, yeah.
Why? Do we know?
Well,
Too political
no,
to talk about?
you can go see the applications. We apparently didn't do a good job on our application compared to Care Oregon
Huh.
in terms of the decision making. So we're happy and pleased with being able to continue to serve the 50,000 members here in Eastern Oregon and continue the structure that we have here. August 1st, MOTA and those folks are coming down here. And, you know,
We have registered a few folks from the clinic. One provider is also going to be attending.
it's not a bad thing for some other folks to kind of listen in on what they're telling clinics and what their strategies are. It's a 2-hour meeting. Noah, Summer, Sarah come out and just kind of talk about the billing issues and
I'll send
Need
you
an
the
invitation,
invitation.
please.
Yes.
I think it's scheduled for this room.
Yes, it is. I'll send invitations.
And then September 19th is the Clinician Summit. I know Nam and Susan went.
It was excellent.
Last year.
It
Yeah.
was an adventure, but it was an excellent.
Well, that's because you shopped and begged on the way up and some things happened. But September 19th, the keynote speaker over lunch is John Kitzauer.
Okay.
And then the September 25th is the Regional Community Advisory Council meeting. It's in Baker City. It's the one that's dedicated to our early learning hubs working with LTACs. So those are
A lot going on.
key dates. Yep.
Does anybody have anything else for the betterment of the group? All right, we'll go ahead and adjourn the meeting. Thank you all for coming in.
Thank you.
There you go.